persistent interest to Helicobacter pylori infection and mainly associated with the role of this microorganism in cancer formation and aims of cancer prevention. The recent years were marked with implementation of two important documents. They are the Kyoto Global Consensus on Helicobacter pylori gastritis and the fifth Maastricht Consensus on diagnostics and treatment of Helicobacter pylori infection. Analysis of 5 Maastricht Consensus proves that the conservative approach dominated, as well as the trend to limit the range of antimicrobial drugs. However, there is the alarming trend. We replaced 7 days treatment regimens with 14 days treatment regimens. We replaced dual therapy with triplex 1 and then with quadra therapy. The expanded question now arises, what is next? Let's discuss this problem together. In the first instance, we should understand where we are. The study conducted in Russia within the recent years proved extremely high level of H. pylori infection in our country. But data which we obtained within past 3 years shows that HP infection varies in different regions of our country within 50 to 70%. Infection level in doctors does not differ significantly from infection level in other citizens. But there is one disturbing feature. H. pylori infection level in doctors increases with age, what is not typical for other groups of the examined people. Probably this is our professional risk. To review the eradication therapy improvement, let us see WHO document dated 2017. This document contains the notice that the growth of clarithromycin-resistant strains of Helicobacter pylori leads to strong need of seeking new medications for the eradication therapy. This situation was described in the last edition of Maastricht Consensus. In the first statement, it is specified that H. pylori resistance to antibiotics is growing in many regions of the world. Situation in Russia is doubtful. According to the opinion of Russian Gastroenterological Association, a lot of regions of our country have not yet overcome 15 threshold of resistance of clarithromycin. However, there are several studies, the findings of which are not so optimistic. For example, our study conducted in 2014 revealed 25% resistance to clarithromycin, 27% resistance to levofloxacin, and 42% resistance to metronidazole. There is one more problem associated with the use of microlide antibiotics. According to our colleagues, clarithromycin therapy is accompanied with inhibition on symbiotic colonic flora growth, in other words, with growth of dysbiotic disorders. The literature sources provide the range of recommendations on improvement of eradication therapy efficiency. The main recommendations are provided in this slide. Unfortunately, we have to admit the fact that they do not resolve the problem completely. Russian Gastroenterological Association points at the importance to search methods to improve eradication therapy to individuate such therapy. People say, what salt is new again? This picture shows shea balances which illustrate the concept proposed earlier than a half-century ago. According to this concept, progression on erosive ulcer diseases is in all cases the reflection of disbalance between the factors of aggression and protection. Previously, our therapeutic activities focused on suppression of aggressive factors, but in the recent years, the factors of protection or cytoprotection attract more and more interest. There are 3 protection levels of mucose of gastroduodenal areas. The key factor of pre-epithelial protection is mucosins, epithelial protection, prostaglandins, and post-epithelial protection, microcirculation. In relation of the cytoprotection problems, ribamypin attracts special interest. Via specific receptors, it stimulates synthesis of endogenous cytoprotective prostaglandins and provides a positive impact to all 3 levels of mucose protection. But in the scope of this presentation, I would like to review only one aspect of its application. I mean possibility to use it to increase efficiency of H. pylori eradication. In 2014, Japanese investigators published systematic review and meta-analysis. This proves that adding ribamypin to dual therapy increased achievement of eradication by 70%, adding it to 3 and 4 component therapy by 12%. Unfortunately, in their study, the investigators analyzed eradication schedules which are not used in our country. One more problem which is not still completely resolved is the schedule of post-treatment for the patients suffering from ulcer disease who passed eradication therapy. The literature sources provide different opinions in relation to this issue. Some authors consider that post-treatment is not required, but this point of view is controversial. The placebo-controlled study conducted by our Japanese colleagues proved that use of ribamypin after eradication therapy contributes to stomach ulcer healing. According to the study of Song, ribamypin and omeprazole are similar in efficiency of H. pylori positive ulcer disease treatment after eradication therapy. The study of Haruma and colleagues are also interesting. They proved that long-term therapy with ribamypin improves histological characteristics of gastritis, decreases level of gastrin, and has anti-inflammatory effect. All of us said motivated us to conduct a study which we titled Bastion. Bastion as a guarding structure was widely used in Middle Ages during construction of the fortresses. In this slide, you can see design of the conducted study. As we can see here, the primary diagnostic of Helicobacter pylori include two tests, rapid urease test and respiratory 13-carbon test. According to the screening results, we formed the group consisting of 60 patients suffering from H. pylori-associated erosive and ulcering diseases. Then we randomly divided all patients into 3 groups, 20 persons each. The patient of first group obtained the standard 3-component therapy. The patient of the second group were additionally administered 120 milligrams of colloidal bismuth 4 times a day. And the patients of the third group were additionally administered 100 milligrams of ribamypin 3 times a day. Duration of the eradication therapy in all 3 groups was 10 days. The control examination was conducted for weeks after completion of the eradication therapy. Here we should notice that the patients tolerated eradication regimen with ribamypin well. This slide shows that reduction of clinical symptoms under ribamypin was faster and more efficient than in other groups. The most important results of our work are shown in this slide. As it is seen, it is the added ribamypin which contributed to significant improvement of the results of the eradication therapy and achievement of eradication level conforming to the levels recommended with the international consensus. Of course, the question now arises: how the results of the eradication therapy will be improved if ribamypin is added to standard 3-component therapy instead of 4-component therapy with bismuth? Such kind of study, which include 13C respiratory test, was conducted in our country by Sergei Vyalov. As his results have not been yet published, I cannot discuss them in details. I just can say that the adding ribamypin to 3-component therapy significantly improves efficiency of the therapy. What are the mechanisms of the above described therapeutic effects? According to the opinion of most investigators, ribamypin does not have the direct anti-Helicobacter effect. We suppose that ribamypin blocks the processing of H. pylori adhesion and stimulated reaction of mucose to this infection. Dear colleagues, great physicist Albert Einstein once said, "Progress is beyond the standard perception of the world." It seems to me that this expression reflects the subject of my speech. We are in desperate need of new approaches in eradication therapy. Cytoprotective approach may become one of them. Thank you for your attention.
Thank you very much, Professor Simanenkov, and thank you for saving the time. We have time for one or two questions for discussion from auditorium. Professor, please tell me, if you have a resistant culture of H. pylori, how many times do you repeat therapy if your previously therapy anti-HP fail? Yes. Where is the end of these attempts?
Yes, it is a difficult problem. We see 1 year. After 1 year, we repeat, but not same other themes.
Thank you. Another question? If no, once more, thank you, Professor Simanenkov.